Hi, welcome to the Heme Consult Orientation video series, video number 21. We're talking about special consult requests, and today we're talking about neurosurgeons. Last time we talked about surgeons, today we're talking specifically about neurosurgeons. And I want to tell you that one of my favorite people in the world is a neurosurgeon, and I have to tell you that they're really cool. They wear these amazing like magnifier type glasses so they can see really tiny things and do some intricate work in the brain. And so neurosurgeons are super cool, and they're not medicine doctors. That's important for you to know when they call a consult to think about the way they think as neurosurgeons. So let's talk about a couple of things that I want to highlight for you as you are talking to neurosurgeons and helping them answer consult questions. Okay, now I talked about surgeons last time. Neurosurgeons have the same thing where there are hierarchical structures, and sometimes the person calling is not necessarily the person with decision-making ability. So you're saying no to the person calling may not be helpful. For the most part, though, neurosurgeons are not necessarily calling their own consults. They usually are actually consulting on other teams that you may also be following. If, for example, they have an intracranial hemorrhage or spinal cord injury, so that's in the context in which you tend to interact with them. So it's important to know that they have structures that are hierarchical and pay attention to that. But the second thing I want to tell you is that neurosurgeons don't want to have anything to do with bleeding. They hate bleeding. They don't want bleeding. They would prefer to stay far away from anything that could potentially cause the patient to bleed. For that reason, they will likely never be comfortable putting the patient back on an anticoagulant. Never. They'll say the patient bled, never, no anticoagulation ever again. Okay. Your job is to avoid the extremes and to say, we see that the patient bled, and now we've addressed the lesion definitively, and the patient should be able to go back on therapeutic anticoagulation 7 days from now. We can be cautious. So your job is to help manage that, to make sure we're not on the extreme of no anticoagulation whatsoever, and then the patient has a major thrombotic episode, but to make sure that you are actually thinking critically about what is needed for the specific patient. Okay. The other thing to know about neurosurgeons is that they typically want the platelet goal greater than 100. Doesn't matter what it is. A neurosurgeon sees a patient, they don't want the platelet count any less than 100. You know what? Sometimes we can accomplish that, but sometimes it's a lot of platelet transfusions and we're still not at 100. And it's important to sit down with a neurosurgeon, or at least get with them on the phone and say, hey, what is the reason why we're trying to get the goal to 100 right now? And just negotiate and just talk to them about that. But recognize that 100 is an arbitrary number, and sometimes the patient can't make that goal. And it's important to clarify, hey, before we transfuse 10 more platelet packs, can we just clarify whether this 100 goal is actually realistic or not? So those are some of the conversations you want to think about. Okay, the other piece is that you want to listen to understand. So sometimes you might just get the impression that, well, they don't want anticoagulation ever. And maybe that is the case, and the person is not necessarily voicing that out. You want to stop and say, hey, the patient has now been off anticoagulation for 2 weeks with no bleeding. How is it that you're still concerned for bleeding? What am I missing? Help them articulate for you what is the reason behind their reticence potentially to avoid therapeutic anticoagulation. Okay. The next thing you want to do is also clarify from them the procedural bleeding risk. So it's like, oh, okay, you did surgery to relieve a trigeminal nerve impingement. Okay, is that high risk, low risk, or medium risk for bleeding? And it's helpful to have them clarify it so that when they tell you that they don't want the patient to be on any anticoagulation, even prophylaxis, for 2 weeks, you'll say, you told me that this was a low risk surgical procedure. Why should the patient be off anticoagulation for 2 weeks? Help me understand. So those are some of the things you think about in helping them to right-size their recommendations to the actual scenario that is before you. Okay. And then the other thing you want to do is clarify the absolute number of days of holding anticoagulation. Make sure it's like, oh, I hear you saying hold anticoagulation for 6 weeks. Are you sure about that? Help me understand. What's the literature? What's the data? So those are the kinds of questions that you make sure that you keep asking. The final thing I want to talk to you about when it comes to neurosurgeons who are making consult requests is don't leave the time to start anticoagulation up to them. Sometimes I'll hear fellows say, when you're comfortable, you can start anticoagulation. And that really is not a great recommendation, because what does comfort mean? My level of comfort is different from your level of comfort. What we do want to do is base it on objective data. So we go to the literature and say for anybody who's had major oncologic neurosurgery, the expected bleeding risk is highest in the first 3 days post-operatively, and then it falls to, I'm making these numbers up, I haven't looked at it recently, but there's a lot written about perioperative risk for neurosurgical procedures. And you want to find the literature that supports you in making that recommendation. And maybe if there isn't one in that specific type of surgery, there's an adjacent one. And so what I'm asking you to do is don't say, well, the neurosurgery attending is not comfortable, therefore we've recommended when they're comfortable, they can start. No, there are pretty clear guidelines about when it makes sense to start anticoagulation post-operatively. You want to find them so you can document them in the chart and you can say, oh, the guidelines are recommending this. For what reason are you deviating from that? What is magical about 2 weeks? Those are the kinds of questions that you get to ask. All right, so next time you have a consult and a patient receiving neurosurgical procedure, look up the literature and see what the literature says about the surgical specific bleeding risk and how long anticoagulation should be held. And see if you can use that to negotiate with your neurosurgeon. Wouldn't it be awesome if all neurosurgeons were also reading all these articles? If they're not, you can tell them, you can share with them what you've read so they can be better informed as well. Okay, I'll see you on the next video.